everyone. I'm Dr. Carmen Poliafito, and I'm here today with Dr. Dennis Marcus, who is a practicing retina specialist, also Professor of Ophthalmology at the Medical College of Georgia at Augusta University in Augusta, Georgia. Dennis, welcome to Retina Synthesis, or welcome back to Retina Synthesis.
Thank you, Carmen. Good to see you.
You gave a very intriguing paper at the American Society of Retina Specialists about DRCR Network Protocol AA, of which you are the protocol chair, which is looking at the role of wide field imaging in the management of diabetic retinopathy. So we'd like to talk about that today.
Sure. Protocol AA was sought out to evaluate some of the work that Jenny Sun, Lloyd, Paul Aiello, and Paulo Silva did with wide field imaging and continue to do, of looking at peripheral diabetic retinopathy lesions, whether they improve the ability to predict worsening. Previous studies have been done by them and other authors with regard to that predominantly peripheral lesions outside the 7 standard fields, that they have a prediction of patients worsening diabetic retinopathy over time. And probably somewhere between these previous studies showed that on color wide field photography, that having predominantly peripheral lesions greater than 50% outside the 7 standard fields on wide field imaging, about 15% of those patients had a potential for greater retinopathy worsening over time. So Protocol AA was a prospective 4-year longitudinal study within the DRCR Retina Network, evaluating diabetic patients with one eye, at least one eye, with non-proliferative diabetic retinopathy and no DME center involving. And it was visits for 4 years, and it was observational to see who got worse, and graded the wide field images over time with PPL, or predominantly peripheral lesions, defined as in any field or any lesion type, whether it be IRMA, microaneurysms and hemorrhages, even NVE or venous beading. Most identified IRMA and hemorrhages, microaneurysms were the greatest. Whether when an eye was defined as having PPL at baseline, did this imaging both on color wide field and fluorescein wide field images, when graded by a central reading center, could this predict which eyes get worse with time with regard to a primary outcome of 2-step worsening of the severity level based on grading within those 7 standard fields on wide field images, and as a primary outcome inclusive any treatment for DR, for diabetic retinopathy, and not for DME or other diseases like retinal vein occlusion. So the primary outcome being 2-step worsening on severity level or treatment for DR. And interestingly, the outcome through 4 years, just to review, we had about 367 participants, 544 eyes, and about 77% of patients completed the 4-year evaluation. Just under 50% of patients had both eyes enrolled in the study. At baseline, patients had a wide variation of non-proliferative diabetic retinopathy from mild to very severe NPDR. So there was a good variation in baseline grading on those masked 7 standard fields. So at baseline, PPL on color images, wide field images, were present in 41% of eyes, and on FA PPL, 46% PPL was present. Now, it's important, as we all know from looking at wide field fluorescein, it provides so much more information just intuitively. And I think that it's important to realize that this is one of the first studies to note that there was discordance of FA and color PPL. 37% of eyes were discordant, whether PPL was present or absent, color ultra wide field images versus fluorescein images. Um, so basically, the primary outcome, DR worsening over 4 years, based on whether PPL was present or not. Color PPL, surprisingly, and not consistent with previous studies, color PPL did not predict diabetic retinopathy worsening. So patients or eyes at baseline with color PPL present, 38% worsened over 4 years as the primary outcome. And if color PPL wasn't present, 43% of eyes worsened. So there was no predictive value in this study of color PPL leading to worsened DR by 2 steps or treatment for DR, interestingly enough. And this was the same lack of risk for color PPL was present at all baseline levels of retinopathy or location or lesion type that defined PPL. So this was somewhat against what was previously found in previous studies, that color PPL in this large longitudinal well-performed study didn't show a risk. However, FA PPL, when identified by ultra-wide field FA PPL when present, did denote a risk of diabetic retinopathy worsening over the 4 years. FA PPL, if present, denoted diabetic retinopathy worsening in 50% of eyes versus if FA PPL was absent at baseline, only 31% of eyes were developed DR worsening. And this was the case, FA PPL predicting increased worsening for all baseline levels of retinopathy. It statistically increased the risk of development of PDR. So FA PPL was a risk factor for PDR developing, and it was consistent for all lesion types, and especially in the somewhat supranasal and infranasal field when PPL was present. And there was so FA PPL denoted a 1.7 risk. So it really clarifies what we see clinically, that FA ultra-wide field imaging increases the risk and can be valuable in looking at both providing outcomes for patients as far as predicting risk, timing of interval of their next exam, as well as hopefully more able to be an aid in clinical research as well in developing other staging systems. And we can stop there. Paulo Silva at the ASRS presented even the more interesting evaluations of non-perfusion evaluation on the fluorescein and risk of DR worsening over time, which I can outline unless you have questions at this point.
I'd like to hear about what Dr. Silver presented. I think it's of interest to the audience.
Yeah. So we know that the ETDRS only looked at 2 posterior fields on fluorescein. And so we really have not had a study of risk of peripheral visual field lesions. And with this data set, basically non-perfusion index was graded by a centralized grading center with respect to NPI, non-perfusion index, being the gradable area throughout the retina on ultra-wide field images as the denominator, and the numerator is how much non-perfusion area is localized. So the NPI, or non-perfusion index, is a good grade for how much non-perfusion, which we see so greatly on ultra-wide field fluorescein angiography. And sure enough, I think this is the great data and part of the great database that of this large longitudinal study. First of all, baseline DR severity was associated with NPI and non-perfusion. Interestingly, consistent with the DR worsening data, that color PPL wasn't associated with overall NPI and non-perfusion, but similarly, FA PPL was associated with overall non-perfusion. And this was located within the mid-periphery and peripheral zones. And then with regard to association of diabetic retinopathy worsening, the level of non-perfusion was associated with the primary outcome of DR worsening. If I had no non-perfusion at baseline, there was only a 26% of worsening over 4 years as the primary outcome. And if I was in the high non-perfusion index category, 46% of those eyes had a 4-year risk of worsening. Non-perfusion was associated statistically with development of PDR as expected and development of vitreous hemorrhage. And those are the key important clinical outcomes that it's clear that that non-perfusion can predict worsening of retinopathy when based on fluorescein. And also the confounding factors such as baseline level of retinopathy. It was found in multivariate analysis that both retinal non-perfusion and FA-PPL were both independently associated with DR worsening over time. So I think that this study supports that non-perfusion and FA-PPL are important. And I think that this data set can provide us with the ability potentially to evaluate a new staging system. We know some of although the 7 standard field, which only evaluates 32% or so of the retina, the 7 standard fields have been a valuable predictor and staging of diabetic retinopathy over time, but clearly FA provides so much more. And I think that this data set can provide us with new, more modern staging systems and clinical research, as well as maybe suggesting that we should use this more often. Certainly I do in clinical practice and have always felt that we learn and identify so much more with baseline fluorescein angiography wide field. And I think that it'll help us advance in helping patients know their risk factors, timing of exams, and so forth. So I think there's more to come with this data, but I think that it certainly supports greater use of ultra-wide field fluorescein.
So how has this impacted the way in which you manage your diabetic patients day to day?
So I think I've interestingly recognized this back when I got out of residency and fellowship, and I think it still stands that the AAO recommendation for evaluating and diagnostic testing of diabetic retinopathy was at that time when the pre-anti-VEGF era and laser was the predominant treatment for diabetic retinopathy. It was get a fluorescein to help guide your treatment with laser of diabetic macular edema, but a fluorescein wasn't necessary to evaluate diabetic retinopathy. And what I noticed as I was treating patients for diabetic macular edema and getting fluoresceins, non-wide field at the time, was that it really didn't help me guide my laser very much. But what it did do in many cases is I asked for peripheral views is identify things like neovascularization more frequently than evidenced on clinical exam. And
Right.
I've always felt that fluorescein is a much more sensitive testing than clinical examination, because I think the problem is many diabetics with proliferative disease are young or phakic and less cooperative even on the exam to be as accurate. So I think this confirms my belief after getting ultra-wide field fluorescein in the last 5 to 10 years and seeing how much it provides, that I've been getting ultra-wide field fluorescein at baseline on my patients for a while. And I think it's always helped identify proliferative diabetic retinopathy, level of ischemia, and helped really assess the eye and the pathophysiology greater than my exam or color photographs. I think more importantly, in the era of looking at earlier treatment for DR, whether it be intravitreal anti-VEGF injections, which are a great treatment burden and haven't been readily adopted by the retinal community, certainly with an emphasis of looking at both oral drugs and topical drops, as well as maybe some more durable anti-VEGF platform, whether it be the PDS or gene therapy in the future, I think that this becomes even more important with respect to assessing experimental treatments that are now being evaluated and trying to assess eyes that are at greatest risk of worsening and maybe find a more relevant treatment than the treatment burden of intravitreal anti-VEGF therapy for prevention of progression of diabetic retinopathy.
So do you think that wide field imaging has replaced the 30-degree camera?
In my mind, it has, with respect to, I think it provides me more information in taking care of patients. I think we still can't go away from the fact in clinical research of the 7 standard fields color photography still remains our gold standard for clinical research. But I think that this data certainly pushes us, and I think the DRCR Retina Network will take this data set and really develop more pertinent information and maybe better information as far as grading of retinopathy and creating a different scale, I hope, to better relate to treatments and clinical research, as well as maybe creating algorithms or FA surrogates to better predict worsening and timing of interval of examinations for our patients.
Is the quality of the images on wide field the same as seven field?
So certainly we all know that there's a level of resolution depending upon the camera. And there are many different factors, especially on the color images. With the fluorescein, there's greater contrast, so the quality seems better. That being said, the DRCR network did compare digital 7 standard field images to the 7 standard field ultra wide field images, and they were comparable in grading retinopathy. There were some discrepancies with respect to in this study of the association of baseline retinopathy levels and progression of retinopathy with the ultra wide field 7 standard fields that are somewhat puzzling. When we looked at the baseline non-wide field ETDRS 7 standard field color imaging, that was consistent with previous studies that have been done, that with increasing levels of retinopathy, there was increased diabetic retinopathy worsening. So there's some question of why that occurred in this study that we haven't been able to answer. Certainly, just intuitively, when looking at images, it's clear that the fluoresceins are much more informative than color, which can sometimes have some compromised resolution. And I've certainly felt for a long time, as I said, that fluorescein was most valuable, and I think this confirms it.
So how do you use angiography these days in your practice in evaluating patients?
So I think most diabetics, patients with very mild non-proliferative diabetic retinopathy, often I don't obtain fluorescein angiography wide field, but patients with significant levels of retinopathy, I often get a baseline ultra wide field fluorescein and have. So this study just supports, I think, what I've been doing. But I think especially in the younger type 1 diabetics who are more ischemic, have featureless retina, not many hemorrhages and microaneurysms that are obvious, those patients that you suspect IRMA or ischemia, I think it's very important to help define whether these patients have neovascularization. And there's so many of those type of patients through the years that ultra wide field has helped identify. Yes, this patient surprisingly has a lot of neovascularization, not obvious on clinical examination.
Does the status of peripheral perfusion observed in this study have anything to do with the development of clinically significant macular edema?
I think very few eyes in this study developed DME. I don't think we've looked at that. I think that's an interesting question. I think certainly other studies have shown that the level of non-perfusion or at least lasering the peripheral retina doesn't help diabetic macular edema well, but that would be an interesting question. I don't think that's been looked at yet.
But I mean, which fundus features were the most prone to predict disease progression?
So as far as this study, not many
Yes.
eyes developed DME, and all eyes here at baseline didn't have DME. So I don't think that we've looked at whether non-perfusion at baseline predicts who'll develop DME, because the primary outcome was if you've got DME, those eyes were censored at the time. So the primary outcome was treatment for DR and not DME. That would be an interesting question of was NPI associated with development of center-involved DME? I don't think we've looked at that yet.
Is there a follow-on study?
So I think this data set is so broad that many studies and further analysis will be coming. As far as follow-up studies, no, but I think the data set will provide us with a wealth of additional analyses, such as the question you proposed.
There are different manufacturers of wide field cameras, Optos, Zeiss, the Zeiss Claris. Does the size of the visual field relevant here?
Yeah, I mean, I think that obviously wasn't looked at. Most of the cameras were, well, all of the cameras were Optos TX because they were defined and FDA approved based on, I think there was some data to support the use of Optos based on their FDA approval of the cameras. Claris was not evaluated in this study. Obviously, Claris is a little different in how the images are obtained and montaged than Optos, and obviously the technology is different. Also, Optos TX cameras were used, and now there's the Optos California camera, which has greater resolution on color images, and but the mainstay of images in this study was the Optos. So looking at differences in cameras and imaging systems were not evaluated, but it would be interesting to know whether other imaging devices are better, worse, the same outcomes. I would imagine they're not too different.
Well, it's certainly clear that you can't really practice state-of-the-art diabetic retinopathy evaluation without wide field imaging.
I tend to agree, and I think that this study supports that what we've been looking at intuitively, that it does provide so much more information, and it supports that it should be incorporated with examinations, color photography, and is over and above can predict worsening of retinopathy.
Well, thanks a lot, Dennis, for your time, and love to have you back as this field continues to emerge.
Thank you, Carmen.